invited some of today's most prolific leaders across the healthcare continuum, who are not only weathering the rocky climate of change in healthcare, but are absolutely thriving. I don't know about you, but I love nothing more than being inspired by other brilliant people. So I'd like to welcome our panel to the stage while I introduce them, and introduce you to their fearless leader, Dr. Alfred Poor, who is the editor of Health Tech Insider, a health tech-focused website and newsletter, which is one of my most trusted sources in my inbox. And his background is quite prolific, so please make sure you read his bio in the agenda. Thank you.
Thank you so much, Jill. And I want to thank you all for coming out so early and making it to the first session like this. It's great to see so many people involved, and we've got a wonderful panel, I think, to help us get the day started. What I'd like to do is just introduce them to you one at a time and hear a little bit about each one. So we'll start with you, Tom. Tom Riley, CEO for SeniorLink, and just the 30-second overview of SeniorLink and your perspective.
Great, thank you. Happy to be here. Thanks to everybody for getting up early. As they said, I'm Tom Riley. I'm the CEO of SeniorLink. We're a $120 million business based in Boston, Massachusetts. I have another Boston item on my left here as well. And we marry collaboration software with care management strategies in support of family caregivers on behalf of multiply chronically ill patients. And we do that on behalf of both government and managed care payers.
Excellent. And then next, we have Rina Pandey, and she's the Chief Medical Officer for Able2, and also from Boston. So, Rina?
Yeah, happy to be here where it's a little bit warmer than back east. Thanks for having me, Alfred. So I'm Chief Medical Officer at a company called Able2, as you've heard. We're a technology-enabled behavioral healthcare provider. I'm a cardiologist by background, which might sound odd, but it became very clear the degree to which behavioral health comorbidities, depression, anxiety, stress, or related disorders were so common amongst patients with chronic medical conditions and really stood in the way and do stand in the way of improved medical outcomes and total overall health. So we have a national network of behavioral health providers who are delivering our best practices, evidence-based care through our technology platform, by phone, by video, supported by digital tools, a data and analytics component of that to help find patients who may be at risk, excuse me, and in need but may not yet know, and a whole engagement capability to try to find those patients and get them into our programs.
Thank you. And we have Zubin Epen, and he's also Chief Medical Officer with CareMore Health. So, Zubin, what's the quick story?
Sure, thanks, and good morning. My name is Zubin Epen. I am the Chief Medical Officer of CareMore. I'm also a cardiologist, so we have a couple up here. CareMore
so if anybody drops, we're all covered.
CareMore is an organization that is now 25 years old who's been in the business of being both a payer and a provider. We insure patients through Medicare Advantage as well as Medicaid, and now are looking to expand that across other lines of business. But importantly, we just not only insure the patients, we actually take care of them. And we have 130,000 patients across 8 states where we have hundreds of physicians, nurse practitioners, and pharmacists who actually provide the care for all the patients that we cover. In this effort, we really try to avoid hospitalizations and help our patients live long, healthy lives outside of the hospital. It's a pleasure to be here with these companies who are trying to do the same. And as we move care from hospital to home, there's obviously lots of use cases for technology that I'm interested to talk in.
Excellent. And so the thing I love about this panel is that we have different approaches, as you said, to the same bigger problem. And the innovation and the disruption that they represent, I think, is a great starting point for us. So for me, one of the things that I see is policy, legislation, government structures that they put out there can encourage or they can be obstacles to innovation and disruption. One of the examples that I cite is telehealth. There was the company that was trying to put remote kiosks in drugstores so that they could consult, and they were doing it in Northern Ohio. They actually had to get waivers to do it because it was illegal for patients to see, for doctors to see patients who weren't in the same room. So whoever would like to go first, what do you see as some of the ways that government either gets in the way or encourages things to happen?
I'll take that. We operate in 7 markets, and we serve both Medicaid only and dual eligible members, so we deal with government every day, all day long. And for us, government's been a great partner. You obviously have to work with them over time, but I would suggest that the Medicaid system in particular has been a venture capitalist for many service companies that have been created over time. There can be some capricious moments as it comes to payment or pricing, but for the most part, I would say our work with government has been quite good.
And I can just echo that. I think government has been very interested in payment innovation over the last decade, and I come previously from a fee-for-service background from an academic health system, as Rena does. And one of the issues with me being a cardiologist trying to take care of heart failure patients is, despite me trying to keep them out of the hospital and the clinic, the only way I would get paid is if I saw them face-to-face in the hospital or the clinic. So thinking about how do you really move care to the home is really stifled by a legacy fee-for-service reimbursement system. Models like Medicare Advantage and Medicaid, which provide a global sum of money to take care of the patients, allow for creativity and innovation in terms of how you might care for patients. A couple of quick examples. In the history of CareMore, one of the legendary stories is the patient in LA during a heat wave who kept coming back to the emergency department time and time again with dehydration. And the social worker and the case managers went into the home, realized they had no air conditioning, put an air conditioner in the room, the patient stopped coming to the emergency department. So those kind of creative, not only clinical but non-clinical solutions that we can do for our patients can be really created by these payment models.
I'm going to play devil's advocate. I think government has been a bit behind in some areas,
All right.
although advancing forward, so I'll give some kudos. On the telemedicine side, CMS, for example, has had in place for a while limitations on the ability to deliver telehealth. So the patient had to be in a so-called originating site, so meaning you had to go to a clinic, and then the doctor or the clinician had to be in another official site, and then that connection could be made. That's softening. Thankfully, there's some legislation in front of Congress now that says, okay, maybe the patient can be in their home, the physician or the clinician could be outside of an official facility. So they're getting there, but those barriers have kept us from, say, directly working with Medicare, fee-for-service, CMS patients. We have cut our teeth working with commercial payers because they can make those decisions to create payment models for telehealth despite government regulations. Medicare Advantage can do the same thing. But fortunately, the government is moving. The VA has been a forerunner in that regard.
Talk a little about the VA, and because a lot of times, when I talk to people, they think about VA hospitals that are 2 days away, and that's the only place you can go to get treatment, and you have to wait a year to get your appointment, and the horror stories pile up. So I think something positive about the VA is worth mentioning.
Yeah, the VA is surprisingly innovative and creative, despite all the flack that the VA gets in the press. They were the first to have an electronic medical record. You and I probably trained 15 plus years ago using their EMR, which preceded everybody else's. And with David Shulkin at the helm, he's been very innovative and actually has lowered the barriers to delivery of telemedicine, and in fact is creating the ability for providers to not have to be licensed in a particular state. Right now, providers have to be licensed in the state where the patient resides in order to be able to deliver care to that patient, even if it's done by phone or by video. And they're lowering those barriers so that physicians can provide care throughout the VA system, which is a real advancement forward.
So do you think that's going to translate into non-VA kinds of health? Do you think the VA success, so to speak, may help states get looser, allow telehealth? How do you read the tea leaves?
Well, I'll say I think Rena is right. The VA has been very creative around these things. I think it does depend on the payment model. So oftentimes it originates with where the money's coming from. And I think in those programs like Medicare Advantage and Medicaid, there are opportunities to think about a global sum of money going to providers who can then deploy creative solutions. I think Rena's also right that traditional Medicare, traditional fee-for-service does not allow for that. So I think as these new models get adopted, that will really help with some of these creative solutions. That's important for everybody in the audience who's developing tech solutions that may not be anchored to a face-to-face visit.
So ACA is a favorite punching bag from just about every direction. Do you see any pluses that came out of that? One of the ones that I see as an example is the penalty for hospital readmissions for certain conditions. As the engineer in me says, that finally closes the loop. If you do a good job, you get rewarded. If you don't do a good job, there's a penalty. Tom, you have any feelings about that?
Look, I think the value-based care horse is out of the barn. We saw this when, DRGs came in the early 1980s. That was initially a Medicare initiative, but healthcare systems transformed the way they delivered care across their payer population immediately. They had to, right? You weren't going to treat somebody differently. I think value-based care and the way providers provide value-based care has started, and it's started in earnest. I don't know if I agree with the penalty model. I think it drives certain behaviors, but
say more about that.
well, as a country, I think part of the problem with healthcare is that we create point solution and point penalties, and then people drive to that, and they change behavior, and then we all wake up and we say, well, that isn't really what we intended.
Okay.
So I think we're doing some of those things to change some behaviors, but in the long run, this notion of truly understanding the need of the patient, the needs of the patient, the social determinants of health needs that were highlighted earlier. I mean, in our business, we focus our attention on the family caregiver because they know the most about the chronically ill member. They not only know that there isn't an air conditioner, they know there isn't food in the refrigerator. They know they haven't applied for fuel assistance in time to get it for the winter time. And that's got nothing to do with the health conditions.
Right.
So I think if we continue down this path, and if, candidly, the folks in Washington don't get in the way, the provider system will, in fact, do what it needs to do to get to the patient and make a difference based upon the patient's needs.
Anything to add?
I completely agree, and I think there was a good start by the hospital readmissions reduction program as part of the broader effort to really reduce hospitalizations, incentivize behavior, but I think you're absolutely right. It's a very pointed and focused solution on readmissions, and I think one of the challenges right now is that there's a lot of controversy if these policies are actually to the detriment of patients, and maybe patients are dying more because they're not getting into the hospital. Data are mixed, but if you ask patients what they want, they really just want to be able to spend more time at home.
Right.
And I think what you see here is a representation of organizations who are trying to do just that, keep patients at home longer. And I think a lot of that really is driven by how do we move care out of the hospital into home, but make it accessible and on demand. The challenge is if you're going to take care of patients in their homes, how do you reach everybody, and how do you know who to reach and when?
Yeah, I would agree. I heard a wonderful talk by Mark Gans, who's the CEO of Cambia, Blue Plan. So heartfelt and heartwarming, and just a reminder that at the end of all these digital tools and all these ideas and all the legislation are real people dealing with real problems and real health conditions. And if you can always just remember that, and I think our three companies have done that. In the end, there's a person, and they need care and they need help, and ensuring that we retain that perspective of the humanity and the compassion that's needed in healthcare as we build solutions and legislation around it to optimize patients' overall.
That's an excellent point. So let's talk about money. People are nice, but it doesn't happen.
From people to money.
It doesn't happen if we can't afford to do it. And so I see a problem that I describe as the left pocket, right pocket problem. Clearly, there are lots of innovative, exciting innovations, programs, disruptive kinds of technologies and applications that can save lives. They save money. They do a lot better at many, many things, and especially the human side of it. But the problem is the savings go into this pocket, but the cost of those programs comes out of this pocket, and they're not always connected. The air conditioner story is a perfect example. Many of you may be familiar with the research that was done in Camden, New Jersey, a number of years ago, where they wanted to address the problem of the frequent flyers in the city hospital emergency rooms, and the top 5% of the patients use more than 50% of all the resources. And they went and addressed this by giving the top few of them a full-time medical social worker and a free apartment. And they were able to save something like $500,000 a month just by doing that. But the problem is, I don't know of any emergency rooms that have a budget that has a line item for a personal social worker or for free apartments. So how do we address this? Are the organizations that are funding these things, are they becoming more aware of this? Is this something that they're open to? Where is the leverage point where we can tip this and help make it happen? Rena, what do you?
I'm happy to comment. I mean, our focus is working with payers,
Right.
And this has been a major problem for us. I feel like we've been educating the payers as we've been building the company over the past many years. For behavioral health, largely these two things have been siloed. Physical health over here, behavioral health over here. And literally payers have for many, many decades carved out, they use that terminology. There are behavioral health carve-outs. They take a pot of money, they give it to another company, and they let them handle depression, anxiety, schizophrenia, bipolar disorder over there.
Not those serious diseses. We'll save the other money for the real diseases.
And then the medical stuff we deal with out of a different pot of cash. And we talk to payers who have essentially a unified P&L. I mean, you have to understand that actually what you want to do is spend more on behavioral health, because we know that a dollar spent over here can save 3 or 4 or 5 of the entire pie. And so that's a reframing that the industry needs. That it's all one person, and you need to be thinking about spending here in order to save here as one big pot.
So Tom, with caregivers, it's a huge issue because as a society, we kind of expect the caregivers to do it for free.
Yeah, and we've spent most of our 17-year history, we've served 10,000 extraordinarily complex people over that period of time. And we spent most of our history saving a lot of money for both Medicaid and Medicare, but getting paid from the Medicaid dollar.
Okay.
So we have a software platform that we call Vela it's a secure messaging environment where we collect intelligence from inside the home, we create clinical protocols, and we spin that back out to caregivers to create better outcomes. And we then measure the effectiveness of that. We have clinical teams that go around as well. And we save 30-40% on hospitalization rates against a comparable cohort, but we were saving the money for Medicare. So now we're seeing that as these pots of money are coming together, as these dual eligible plans are being created, folks that are running those pots of money see that the trade-offs between taking care of social determinants of health and doing that well has a real trade-off in hospitalization rates, and that's a trend, I think.
Cool.
Yeah, I think what Tom and Rena are really getting at is this idea of a global payment to allow providers to determine what does the patient need and how do I provide it, I think is a way to make sure that there's not carve-outs or different pots of money. And I think that's been really important for us at CareMore is to say that we will take a certain amount of money per patient and then we'll decide how best to deliver the care to the patient and what else they need besides typical clinical care. So other examples of services we provide, we've partnered with Lyft to provide ride sharing for our patients so we make sure that they can have access to the services they need in our clinics. We are delivering meals to patients after hospitalizations who can't cook for themselves. We started a togetherness program where we are taking care and addressing senior loneliness and recognizing that senior isolation is really leading to more health problems. A lot of people ask us, how do you get that paid for? And the answer is, we pay for it. And I think as we move care from hospital to home, we are looking for those technologies and those solutions that can help us drive all of that back into the patient home to figure out which patients are doing worse. So we're looking for great holistic, disease-agnostic, remote patient monitoring solutions that can help us identify which patients are doing worse and tailor those services for that patient.
And it also seems that large employers who are self-employed, self-insured, who are insured but see a performance-based cost for that. It seems to me, certainly with the lower level, the fitness bands and things like that, they're getting on board with making that investment up front because they're beginning to see the payoff behind it. Is there more that the government could be doing, the states, the again, coming back to this sort of structure that we have to operate within. I mean, for example, I know the states have gotten very active within the past 4 or 5 years of relaxing their telehealth rules. The majority of the states now have something in place. It may not be perfect, but there's been a big advance in that. What other kinds of changes do you think could be done to help push this along?
Well, I'm excited to be here 2 days after Congress passed, it might be its first and only joint bill called the RAISE Act, where Congress has given itself 18 months to create a strategy for family caregivers in this country. And usually, if we had more time, I'd ask for a show of hands on how many family caregivers are out there. There's 40 million of you in this country, There's 40 million of us doing this work. And for those of you that are out there doing this work, I would say to you what I say to a service person I see out on the street corner: thank you for your service to our country, because you provide $500 billion of uncompensated care to our $3 trillion healthcare ecosystem. And those in Washington are finally getting their act together to recognize the value of that and to do something about it. We've been doing it for 17 years, but there are times when we feel like we're toiling in the vineyard, so to speak.
And pushing the rock uphill. Zubin?
Yeah, I think really accelerating this transition from fee for service to fee for value, I think, is going to be really important for us. In Boston, I think you all have you've been at the vanguard of some of this. I think where I am now in California, it's we've been at the vanguard of this, but a lot of the country is not, and I think they're really stuck in a fee for service model where they don't know how to adopt telehealth, as you said. They don't see the incentives to do that, and they're used to just seeing the patients back in the hospital or back in the clinic. And that's not what our patients want or need. And so I think if we think about this fee for value as a broader framework and accelerate how we might do global payments and global capitation, I think that will go a long way.
Yeah, I would have said the same thing, which is, the genie's out of the bottle or the horse is out of the barn on value and quality as a guidepost for payment models. And I think continuing to advance that, right? Moving away from the perverse incentive structure, which we have survived and lived in for many, many years, which is do more, get paid more. And really it should be do better, get paid more. And that's the shift that's happened. And I think the government and payers of all stripes need to continue to push that. The challenge there, though, is, and we run across this as a single solution that's selling two plans, is they get wrapped up in how do we know whether your solution or their solution or another solution was the one that created the value and drove the benefit in the patient. This concept of attribution, and they get so hung up on this that they end up doing nothing. And so I think there's a lot of work yet to be done to figure out how we embed quality and value-driven payment into the system.
So is it a lack of hard information for them? I mean, I feel like I see lots of studies that show this innovative program and 30 to 40% savings, $5 saved for $1 put in, readmissions cut in half. I mean, it's I don't think that we're lacking in hard support for information for this, but is that a problem?
I mean, I think it's a giant multivariable logistic regression model, ultimately, which sounds really nerdy, sorry. But they struggle with that, right? So we have data, we've published our own data saying that by addressing behavioral health, you can keep patients out of the hospital by the tune of about a third fewer hospitalizations within the next 6 months. But then, all the other people touching that same patient may say the same thing, and not to diminish our own data. I happen to love it and think it's correct. But as the payer, so do I dole out $1 million here, $1 million there, $1 million there, and suddenly the entire pot that's available to be delivered to these vendors is diminished. It's just it's a challenge for them. There is plenty of data, but I think teasing out how to give out the funds in the right way is still challenging.
Yeah, I mean, we've taken a little bit of a different approach. The collaboration software we built is designed to have the caregiver at the locus of care for this complex member, but to encourage all the various providers of care to be in this virtual care environment so that they have access to the latest information, permission-based access, so certain actors in the room can see things and others cannot. And I think if we all could wave a magic wand and say, without, integration, can I get somebody to take a picture of the latest med that just showed up and have all the practitioners involved in that complex member's care see that med, I think we'd all say, do that around 5 central things and we'll bend the cost curve.
Yeah.
So part of this is, to Rena's point, trying to find solutions and environments where the information can become available to practitioners and payers so they can see how the pie is being divvied up.
Mm-hmm.
I mean, the one thing just to add is I think if your companies or your products or services are focusing on the provider as an end user and helping him or her do their job better and easier, I think that's low-hanging fruit and could be a slam dunk. If it is about improving patient outcomes, I think there's a lot of data out there, but not necessarily a lot of high-quality evidence. And not to say that we need to do large randomized trials like we do with drugs, but we do need to know, is it better than other ways of taking care of the patient or other standards of care? And there's a lot of studies with mixed evidence for something like remote patient monitoring, which I talked about earlier. Mm-hmm. So I think it depends on how we're, making the value proposition for any single company. But depending on if you're saying that you're improving it for the patient, some of those studies need to be more rigorous studies to really drive adoption by the providers.
So let me we're close to wrapping up here, but let me just piggyback on something you just said. We've got somebody out there who's got a great idea, and they're listening to all this, and they're hearing a bunch of different messages about the road that they're going to have to travel to get to where they're going to go. So if you could tell them one thing about what it's going to take to get them across the goal line, about this whole regulation structure that they're going to have to deal in, what would your advice be?
For me, and I'll talk from a CareMore perspective,
exactly.
We are looking for something, and we talked about this backstage, that really is a holistic solution for helping us understand which patients are doing worse in their homes. There's a lot of pointed and focused solutions on a very specific disease or a very specific set of circumstances, and that's tough when we're taking care of 130,000 patients across 8 states. So if there are holistic solutions that can help identify which patients are getting sicker, that will help us a lot. And we're ready and willing to adopt and think about how do we use those technologies because we have a care model that will fit well with it.
Excellent. And Rena, what advice would you offer for people who are thinking about starting into this?
Make me distill it to one piece of advice. It's a challenge. I guess I got to go back to they always remember the patient, the consumer, the human being at the end. But at the same time, you can't forget the CFO at the other side of the coin, right, who is paying for that solution. And so you have to always be thinking from the patient's mindset, but also be thinking about quality, value, and ultimately ROI, and financial return for the payer.
I saw a Twitter post from Lisa Suennen, who runs GE Ventures recently, and she said, services are the new black. So my advice would be don't develop technology in a vacuum. If you don't offer services with your technology, partner with organizations that do, because together is where the power lies.
And I guess I would add, you can always consider Mark Twain's advice about exercise. He said, sometimes I feel the urge to exercise, but I find that if I lie down for 15 minutes, the feeling passes. So anyway, I wish you all great success in the projects you're doing. I want to thank the panelists for joining me this morning, and I've learned a whole lot, and I think this is great. So thank you all.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you, Alfred.